Hi, everyone. My name is Nora Bennani. I am a faculty within the Division of Hematology with the Lymphoma group. It is my pleasure today to talk to you about a new diagnosis of T-cell lymphomas. And the way I will structure this is basically how I talk through a new diagnosis with one of my patients when I see them in the clinic. You were told that you have a diagnosis of T-cell lymphoma. Now what? Or there is a suspicion of T-cell lymphoma. We always emphasize, and I cannot emphasize this enough, that it is very, very important that our expert pathologist gets the slides if those biopsies were done elsewhere and have them reviewed by our expert pathologist. And the reason for that, those are relatively rare diagnoses, and they are very difficult to diagnose, even for our pathologist. So whenever a pathologist, a pathologist takes longer than a week to give me a diagnosis, I know that it's going to be a T-cell lymphoma. That's typically the case. That's why we do emphasize that we get an excisional biopsy, meaning removing a big chunk, the whole lymph node. If not, if we can remove the lymph node, we will remove it. Otherwise, a big chunk of that lymph node, because that will help them more with the diagnosis, because there are several things that go on into making the diagnosis. Looking at the lymph node under the microscope, the structure, where are the cancer cells, and so on and so forth. So having a big chunk of that tumor is very, very helpful to our pathologists to make a diagnosis. Having an extra set of eyes review those slides is extremely important. So now we talked about the biopsy. Now the staging. When I see a patient with a new diagnosis of T-cell lymphoma, I often will say, we need labs. We need to see how your organs are doing. Is there increasing calcium, which can be seen in some of our patients? This cancer is involving the bone marrow, and that sometimes will be reflected in lower blood counts. So we do that. We also tell our patients that we need to get HIV testing, hepatitis B and C, because those have treatment implications. That's important. We do it in all our patients. We sometimes will order a bone marrow biopsy, which helps with the staging workup, and we will also sometimes do additional testing based on your presentation. But one major test that we do as well is a PET-CT scan. The PET-CT scan will go from head to toe. They will give you a radioactive sugar that basically will be absorbed by anything that is lymphoma. Okay, it will light up, basically. There are some organs that typically will light up, the brain, because we use sugar. Our brain uses mainly sugar. Our kidneys and bladder, because that's how you clear the contrast. But anything else that lights up could be either infection, inflammation, or a cancer, and in this case, a lymphoma. Okay, in the setting of a lymphoma diagnosis, we will assume it is lymphoma. All right, you are going to be asking the question, what stage am I? And here is how we look at staging. So when there are some lymph node regions that are affected, either above, in the chest cavity, above the diaphragm. The diaphragm is a muscle that sits between the chest cavity and the abdomen. When one region of lymph nodes is affected, either above the diaphragm or below the diaphragm, that is a stage 1. Okay? When more than one region, there are a few regions either above or below, it is going to be a stage 2. Stage 3, when we have lymph node regions that are affected both above and below the diaphragm. Or if the spleen is involved. Actually, the spleen, if you didn't know that, is a lymphoid organ. It's actually like a lymph node, all right? When the spleen is involved, it is a stage 3. when the bone marrow, on top of lymph node involvement and all of that, the bone marrow or other solid organs like the liver are involved, then we are talking about stage 4. And, this is relevant because that affects how we are going to treat. And also it does affect the prognosis. The higher the stage, slightly worse the prognosis will be. Okay. So the things that we take into account when we want to treat. So we think about what type of T-cell lymphoma you have. T-cell lymphomas are not one type, and they are not equal in terms of how they're going to affect you. So the subtype of the T-cell lymphoma, and we are talking about approximately 30 subtypes of T-cell lymphomas. How we are going to manage, so the T-cell subtype will dictate how we may treat you. Certain clinical characteristics, including the staging, so the stage will affect how we will treat. How old are you? Okay, so the age is taken into account because certain treatments can be too aggressive for someone who is, let's say, 80 or 85. We do not want to cause more harm than good. And chemotherapy or aggressive chemotherapy is not to be taken lightly. And how functional is the patient? If someone is very active, young and active and, strong, we may treat more aggressively. Someone who is very debilitated, we will take that into account. And are there any other medical issues? For example, if someone just recently had a heart attack, we are going to take that into account in terms of the choice of the chemotherapy because some chemotherapy drugs may affect heart function. Okay, and there are some things that we take into consideration that will affect the prognosis. So age is one of them. The performance status is one of them. The lactate dehydrogenase, that's what we call the LDH, is a blood test that can easily be done just by sending this blood test to the lab. And when that is elevated, it does reflect the tumor burden, how much disease a person has, and also sometimes the aggressiveness. The number of the extranodal sites that are involved. So if they are this lymphoma is affecting the kidney, affecting the liver, that makes it a bit more difficult to treat at times. And we lump all these that I mentioned into a score. You give a point to each one of these. Age more than 60, LDH elevated, ECOG, which is the performance status, how the functional is the patient, and the stage, and the extranodal sites. And then it gives us a score, and based on that, we know that can affect the score. That's what we call the International Prognostic Index score.
I want to express our sincere thank you to our patients, to the members of our Mayo Clinic Lymphoma Disease-Oriented Group, to the Mayo Clinic, and to the Goldman Philanthropic Partnerships for this generous gift to produce this series. This gift has an incredible duality in that it goes directly toward enhancing patient care and provider education. We are at a time of phenomenal rapid change in the treatment plans, the biology, and approaches to clinical care in patients with lymphoproliferative disorders. This project will serve to inform. Again, our sincere thank you, and in the words of Dr. William Mayo, quote, "The needs of the patient come first."